Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is April 19th, 2024, and I'm your skeptical host, Ken Milne. The title of today's podcast is Don't Be Fooled by the Meds I Got. I Still Need an ESP Block for my rib fractures. And our guest skeptic and the person who selected that song but declined to sing the intro is Dr. Suchismita. She's an assistant professor and director of research in the Department of Emergency Medicine at the NYU Grossman Long Island Hospital campus. Welcome back to the SGEM, Suchi.
Thank you so much for having me back, Ken. I'm so excited to be here.
Well, I'm so excited to hear your feedback on your husband Neil's first outing as an SGEM Hop faculty member. How did you think he did? And remember, this is being recorded.
I think he did pretty well, but he is a massive nerd, so I was not very surprised that he did as well as he did.
Oh, he did fantastic. He brought his A game, as we say in Canada. He brought his A game, eh? No, I thought he did a great job, and it's so good to have a couple of people that actually know each other really well that can participate in the faculty and sort of give feedback to each other in a safe space.
Yeah. I don't know about the safe, but yeah, we do give feedback to each other.
All right. Well, before we get into some marital disharmony, why don't you give us a case for today's show?
Sure, Ken. So, you're doing great things and helping many patients during your really busy ER shift, and you all of a sudden hear a trauma alert being called overhead. So you walk over to the trauma room and you see a healthy-looking 52-year-old male who's complaining of chest trauma after being involved in a motor vehicle collision. His imaging shows mildly displaced rib fractures of ribs 4 through 7. He's stable, but complaining of pain despite initial IV Tylenol or acetaminophen. You offer him some opioids, which he says makes him throw up. And he's been texting with his daughter, who's an emergency medicine ultrasound fellow, and interestingly, she mentioned to him about how you can use the ultrasound to inject something to decrease his pain.
And isn't it interesting that everyone has someone connected to the healthcare field that they can text at the time of service to inform you of how to provide care, which is good. You know, it's nice to have someone advocating for the patient. So we've covered rib fractures only one time before on the SGEM, and that was on number 324. And we were looking at using spirometry to guide discharging older patients with rib fractures. The evidence was not robust enough back in 2021 to confidently use this potential tool.
That's right, Ken. We know that rib fractures are associated with an increased risk of morbidity and mortality, specifically related to hypoventilation-related complications. These risks are particularly high in the elderly.
Ooh, and speaking of the elderly, there is a clinical decision tool that I just became aware of called Stumble. And it's the Stumble score, and it was derived and validated by Battle et al. In 2014 in the UK. And it risk stratifies older patients with blunt trauma. There was an attempt made to externally validate this tool in New Zealand in 2021. You know, it didn't perform as well, which is not unusual for a clinical decision instrument. But this recent exchange and finding out about the Stumble score has inspired me to look at doing a research project here to externally validate the Stumble score in a rural Canadian population.
That is so cool. And we all know we need more studies in the rural setting. So great job with that, Ken. I'm really excited to see what you find out from your studies there. We also know that rib fractures can cause lung splinting, and therefore pain management is a very important part of the management of rib fractures. In addition to coming with a litany of undesired systemic side effects, such as depressed level of consciousness and decreased respiratory drive, opioid pain medications are also short-acting and require frequent redosing.
And with the 2014 Center for Disease Control and Prevention declaration that prescription drug overdose is one of the top 5 health threats, there has been a movement away from opioids as the mainstay of pain management for rib fractures. There have been some studies that looked at the efficacy of alternative pain management strategies, but very few have looked at the efficacy and safety of an ultrasound-guided erector spine plane block.
So that brings us to our clinical question today, which is, how effective and safe is an ultrasound-guided erector spinae plane block in patients with rib fractures?
And so what's the reference that we have to answer, or at least try to answer, the question you just posed?
I'm glad you asked. We're going to be talking about the study, Efficacy and Safety of Ultrasound-Guided Erector Spinae Plane Block compared to sham procedure in adult patients with rib fractures presenting to the emergency department. A randomized control trial published in Academic Emergency Medicine, April 2024.
Oh, we're going to have to get you to learn to say, oh, that means it is hot off the press. All right, let's go through the PCOT. What was the population?
The population were adult patients with confirmed rib fractures and a numeric rating score, otherwise known as NRS, greater than or equal to 4, despite routine analgesia.
Yeah, I don't see that many people who come into the emergency department and they're asked, oh, what's your pain on a score of 0 to 10, saying that they're less than 4 presenting to the emergency department. More often, I get people saying stuff like 11, 12, 13, and I'm like, I don't think you understand the 0 to 10 thing, but they're in a lot of pain. There were a number of exclusions. We'll list those in the show notes. What was the intervention?
The intervention was an ultrasound-guided erector spinae plane block, or ESPB, using a high-frequency linear array transducer. The procedure targeted the transverse process, which corresponded to the fractured rib, where 0.5% bupivacaine was injected after initially confirming needle placement with normal saline.
And Suchi, you mentioned in the title there was a sham procedure. Is that what they compared it to?
Correct. There was a sham procedure, or a placebo, which involved similar preparations, but without actual needle insertion or injection.
Whenever I read the term sham procedure, I think Shazam, but that's dating myself. All right, so what was the outcome, the primary outcome in this case?
The primary outcome that this study looked at was the reduction in pain intensity, important outcome, and it was measured using the 11-point NRS at 6 time points over the course of 12 hours.
And what were their secondary outcomes?
The secondary outcome was the amount of rescue analgesia and morphine equivalents, and also the occurrence of any adverse events.
And the type of study?
The study was a randomized control trial. It was prospective and interventional.
Well, I've already spilled the candy dish at the front door here, so people know that this is an SGEM hot off the press episode. And one of my superpowers is being able to mispronounce names. I did the intro singing of something that is not from the 1980s. So, Suchi, I am going to ask you to do the introduction and show how that you can pronounce all these names correctly.
Absolutely. I am so excited to introduce everyone to Dr. Manu Ayyan. He is an associate professor at the Jawaharlal Institute of Postgraduate Medical Education Research in Puducherry, India. Dr. Ayyan is a nationally recognized educator and the recipient of the 2017 Indus EM Emergency Medicine Leadership Award. That's so amazing.
Well, you did a much better job of introducing him than I did. So welcome to the SGEM, Manu.
Thank you, Dr. Ken, and thank you, Dr. Suchi, actually, for inviting me and allowing me to talk about the research which we have put out in academic emergency medicine.
Well, I went back through our 12 years, and I think this is the first time we've had someone from India on the SGEM, and that's a little embarrassing to me because FOMED is a worldwide thing, and India is the most populous country in the world. What took us so long? I am so happy to hear from you. So maybe you could tell us, what's it like to be an EM of India?
Let me just take you to the history of EM in India. So Indian EM actually, started as a specialty, was recognized by the government and the council, which is kind of like the accreditation body. in 2009, almost a decade ago. So then, over years, we have multiple residency programs start to come in the country. So if you look at the statistics now, we have around 250 residency programs across the country, and we have around 550 residents in training. So this is, what EM is currently in our country.
So you're coming on strong after only starting in 2009. I think the US, Suchi, started in the early 1970s. And so they've had a 30 to 40 year head start. But India, you're coming on strong with that description of the program. So glad to have you here. One of the things we do is we get the lead author or the author that's on the show to read your actual conclusions from the abstract. So Manu, could you read the conclusions from your study?
So our conclusion was that ultrasound-guided erector spinae plane block resulted in significant reduction in pain intensity over the study period, reduced the amount of rescue analgesia, and had no discernible differences in the adverse events when compared to a sham.
Okay, so now we're going to go through a quality checklist for randomized control trials, because this was a randomized control trial. And then we'll go through the results briefly. And then we're going to bring you back to ask you some nerdy questions to see if we can understand your manuscript even better. So Suchi, you're up for the quality checklist. Here we go, 12 questions. Are these ED patients?
Yes, this study was conducted at an academic tertiary care emergency department in southern India.
And how about the randomization? And if you mention block randomization, I'm going to think that you tied that into the theme music.
I feel like I'm under pressure to make some kind of music out of it. But yes, the participants were randomized into two arms with a ratio of 1:1. Block randomization was done by random allocation software with variable block sizes.
All right, so you did get block in there, and not only was the intervention a block, but the randomization was done in blocks. All right, so the randomization process, did they conceal it?
They did. They were sequentially numbered, sealed, opaque envelope method, which was used for allocation concealment.
All right, and how about the patients? Were they analyzed in the groups to which they were allocated?
Yes, they were.
And were the patients recruited consecutively?
Absolutely.
Do you think both groups were similar at baseline?
I think so, but the skeptic in me wants to say that there was some incomplete reporting of comorbidities.
Okay. And how about masking? Was everyone unaware of their group allocation?
So the answer to that question is a yes, no, yes. So the patients were masked. The clinician that was actually doing the procedure or the investigator was not masked. And the outcome assessor, which were the emergency medicine residents recording the NRS, were masked.
So yes, no, yes. All right. All groups, were they treated equally except for this intervention with the injection or this sham procedure?
Yes. So they were treated, except for the sham procedure, the patients did not have any kind of skin puncture with the needle for the control group. Otherwise, everything was equal.
Oh, I might want to dig into that a bit. Okay. So how about the follow-up? Was it complete enough?
It was outstandingly complete. 100% follow-up for both groups.
You can't get better than 100%. All right. All patient important outcomes, do you think they were considered?
Almost. A lot of really important patient outcomes were considered, but I would have liked to know a little bit more about the patient comfort during the procedure, their overall length of stay and how it was impacted by the procedure, and potentially some morbidity outcomes.
So what you're saying is unsure, but you don't want to go as hard as no, and it's certainly not a yes because you had some other outcomes that you wanted to see. So an unsure, would that be fair?
That's fair.
All right. The treatment effect, was it large enough and precise enough to be clinically significant?
Again, I'm going to go with yes and no.
Oh,
so
you make things so complicated, Suchi. I think I need to get Neil back on here. Yes, no, Ken. Yes, no.
That hurt. That hurt, Ken. So let me back myself up. I think there's some subtlety here. So Manu and his awesome team of scientists did a great job. They did a statistical analysis before during the study and figured out how many patients they needed to recruit in order for this study to be statistically significant. And they were correct. They recruited 46 total. They recruited 46 total patients, 23 in each group, and the results were statistically significant. However, as an ED physician, a clinician, I still have my doubts about a study that was only performed on 46 patients.
All right, so you're a skeptic.
I'm
All right,
a
the
skeptic.
final question. Who paid for this? I mean, did Manu get a whole bunch of money? Does he have all these conflicts of interest with big ultrasound?
I'm pretty sure that Manu wishes that he does, but he unfortunately has no financial conflicts of interest. There was no commercial funding. This was actually funded by an educational grant. Congratulations on that, Manu.
Thank you.
All right, let's go through the results. You did mention that they had 46 patients that were included in the trial. The mean age was around 50 years of age. The vast majority, and what I mean by vast majority is 87% were male and 61%, so almost 2/3 were due to road traffic accidents. It must be busy in India with road traffic accidents. What was the key result?
The key result was that pain intensity during the study period was significantly lower in the ESPB group within the first 2 hours, both during rest and deep inspiration.
All right, and can you give some more information on that primary outcome?
Sure. For the pain intensity, there was a statistically significant reduction in pain that was noted at 30, 60, and 120 minutes, both during rest and during deep inspiration, but not significantly at 360 and 720 minutes.
So it seems to work well for the first couple of hours and then faded out after that when they took the outcome measure longer. How about their secondary outcomes?
So the secondary outcome regarding rescue analgesia needed, the median rescue analgesia dose as measured in morphine equivalents was 10 in the ESPB group and 20 in the placebo group. There was a statistically significant reduction in the rescue analgesia requirement in the ESPB group.
All right, and there was no statistically significant difference in the occurrence of adverse events among the two groups, and no serious adverse events in either group. And with a small sample size, we would not expect to pick up rare complications or rare side effects. This is where we bring Manu back into it. We have 5 questions for you. Are you ready to go, Manu?
Let's go for it.
So, our first question for you. This study was a single-center trial done in India. Do you think it has any external validity outside your academic site or even in other countries?
We actually included all the adult patients. So, we actually, excluded all the pediatric patients. So, the study doesn't look at pediatric patients at all. Now, looking at validity, if you look at population validity or task validity or measurement validity, if you divide external validity into these 3, population validity wise, ours was a level 1 center, which gets a lot of trauma. So application to emergency department, which has a high input of trauma, this would be a great place where you could think about external validity of these on the basis of population. Now, task validity wise, the focus and nerve block. So when you actually have a program which has an nerve block program running or an ultrasound program running, your team is actually very proficient in doing it. So that is one thing which could be thought about when you are thinking about nerve blocks as such, and probably thinking about validity and probably thinking about applying this to those kind of settings. Regarding measurement, we use NRS scores. We used which is usually commonly used in most of the nerve block assessments when you look at pain score. So answer to that question would be yes, it's valid in most of the academic emergency departments, but then not in departments who are actually starting ultrasound program or very young departments.
All right, thanks for answering that about external validity. But my nerdy question, which is question number 2, sort of links into that, because when you look at ultrasound studies, it really is a bit of the art of medicine. And so this had a single investigator, and that single investigator is the one who taught the intervention. And so it's really operator dependent. And it would have been really nice to see more investigators to test interoperator dependency, interoperator reliability on being able to do these blocks, because we do know that with ultrasound, there is that technique, that art with it.
Yeah, you are right. If you see, our center actually does a lot of nerve blocks. But looking at ESP, if you look at the history of ESP also, it's the procedure itself became popular in 2016. So for us, this is something new. We have been, just starting. Now, as part of research, when you think about doing it accurately and when you are trying to measure the efficacy, the thing which came into our mind was to have a single investigator, because that ensures that you are delivering the drug at the right point and at the right place so that you can measure the efficacy. So yeah, we could have done it with multiple investigators, multiple clinicians who would actually do this. We could have taught, but then as part of the study, we thought, we'll start with a single investigator doing the procedure.
Kind of tying into that, Manu, I was curious about what the effect of investigator proficiency had on the procedure outcome. How long did it take to complete the procedure? And is it feasible to perform these procedures during a busy clinical shift in the ED?
Great question. So, you look at ESP. Has a very steep learning curve. It's one of the easiest plane blocks to do. Now, I'll tell you why. Now, if you look at serratus anterior plane block, you need to actually inject the drug just above the serratus anterior between the plane of two muscles. Now, in ESP, the difference is that you have bone and you have the transverse process and you have the ESP muscle. So you just actually inject the drug just on the bone. You hit the bone and just above it, just below the muscle. So it's much more pretty easier to do. Now, if you look at the learning curve, if you look at ACEP's recommendations, they would tell that for a procedural guided ultrasound, to become competent, you would have to have 10 quality, at least 5 to 10 quality reviewed scans to be done. And that is what we did in our study. Also, we had the provider who was doing the procedure to actually learn needle tracking 10 times and then do the procedure 10 times under supervision. And that's how we actually, started the study. Now, the question regarding how long it took for us, actually, for the procedure part, it hardly took maximum of 10 minutes to do this. Now, in a busy area, like, if you look at our ED, we get around 300 to 350 patients per day. So it's busy. Now, what we found was that if you have a specific checklist and you have a specific method to actually aggregate whatever you are going to do as a nerve block kit. So we had these nerve block kits prepared. So if you look at in the article, we actually have a picture of the nerve block kit which we had. So we had these pre-prepared packs which were actually prepared by the nursing team, and this was kept. So your only thing was to get your ergonomics right, and you had the patients to be, placed in the place where you are going to monitor them, and then have this kit opened, and you could do the procedure within minutes. So this could be done faster if you have these pre-checklists done.
Did you hear that, Suchi? 300 to 350 patients a day?
I know. I have to be honest, I kind of blanked out for a few seconds when he said that, because that's a lot of patients, Manu.
Manu, how many physicians do you have on shift at one time, and how many rooms are in your emergency department?
So pretty much unlike how you see in US or in Canada or in Singapore. I've had the opportunity to work in Singapore for some time. So our structure of how patients are brought in are a bit different. We don't have ERs or emergency rooms. We have zones where, we call it red zone or yellow zone, and these are zones where we treat patients. The question about physicians, we have at a time around 5 physicians and at around 8 to 9 residents on the floor to manage per shift.
All right, time for nerdy question number 3. And this is going to combine that superhero reference I gave earlier about Shazam. So this is about the sham procedure. This placebo-controlled trial used the application of a blunt needle tip to the skin of the patient, but you didn't actually break the skin. I'm curious, why didn't you just inject some normal saline to make this a high fidelity placebo trial? This would also serve to mask the investigator in addition to the patient and remove one of the potential biases.
So we know that placebo is an inert substance or an innocuous substance, which we use when we are trying to clearly compare a drug or an intervention. So now, if you look at nerve block studies, there has been a lot of criticism in most of the RCTs which actually use placebos, which are actually not inert. Now, there has been a latest, article even scoring the sham into sham 0 to sham 4, especially for nerve blocks or local anesthetic studies. And if you look at the scoring as such, it goes from 0 to 4, where you have 0 with no procedure done at all, and then you have 1, which you have a minimal risk of having a harm, where you have just skin allergies, where you are actually basically painting the area and draping basically doing the draping. You have a score which is minor, which have you could have a harm like causing a hematoma after you have actually you're entering the needle, or the needle enters the skin and then pierces the muscle, and 3 and 4 where you actually inject your placebo. Now, normal saline itself might not be a really inert substance when you are actually thinking about injecting it inside the plane, and there is a risk that you could go inside the muscle and create a hematoma also. So as such, if you look at declaration of Helsinki, which tells that patients who are given placebo or no treatment will not be subjected to any risk of serious harm or irreversible harm. So when we actually thought about this ethically, doing a sham 3 or a sham 4 was technically against Declaration of Helsinki, if you look at in that perspective. And for a block like erector spinae block, where you actually are doing the block actually on the back of the patient, you could very well paint it, drape it, and then apply some pressure, because they are already in the having considerable amount of pain in the back, and unlikely that they would know that sharp needle has gone in or you have injected the drug. So that is the reason why we thought that we will not go in for a much riskier procedure of injecting, or even taking a big needle and going inside the muscle and doing the procedure.
Well, thanks for giving us a further explanation on that. Every intervention has a potential benefit and potential harm, and that includes doing a sham procedure or placebo procedure. And so it's a trade-off, and I appreciate that additional information.
So nerdy question number 4, Manu. So I kind of alluded to this before, but I was very curious. Were these patients multi-trauma? Did they have any other injuries? Did you consider anticoagulation use? Did you have INR, PT, PTT cutoff for the procedures? Did you think about any other comorbidities as prognostic factors?
These were actually our limitations. If you look at, we explicitly didn't actually factor in or take a note of what are the other injuries associated with the patient. Most of them had some associated injury, but when we were actually asking them the pain score was actually asked specifically that whether you have a pain in the chest because of the injury which has occurred in the chest. So that is something which we did, but it's not really a tight this thing that we actually excluded any polytrauma patients. We included all of them. Now, regarding anticoagulant use, we didn't explicitly exclude patients who are on prior anticoagulants. We actually, if you look at in the complications, we did not see any complications related to bleeding or hematoma formation in the study. Comorbidities, yes, we again did not measure, or we did not take that into our outcome measurements, because we felt that these would not really affect the acute pain measurements, and that is the reason why we did not measure those in that regard.
So I'm going to get out my soapbox here. One of the things that I've been advocating for is to include more pregnant women in studies. In your case, this trial, pregnant women were an exclusion. It seems you could make a reasonable argument that pregnant women would benefit from non-opioid pain interventions and are at particularly high risk of splinting and hypoventilation just due to the fact that they have decreased lung volumes due to their pregnancy. So, do you have any response about why pregnant women were excluded from this study? What was the rationale?
So you are right. The nerve blocks as such would have a opioid sparing effect on pregnant women, and that would be great. The problem why we did exclude was that, when we thought about and we looked at our data, we didn't have much incidence of pregnant trauma coming in. Now, even if we had actually included doing a subgroup analysis and actually finding out if this actually benefited them in that regard, would be a very difficult task with very few samples. So that is why this was one reason why we thought we'd not. And the second reason was logistically and ergonomically, doing the procedure on a pregnant woman would be much tougher. So these are the two reasons why we thought we will not include them.
Well, that's good to hear that there are not a lot of pregnant women having rib fractures. So I'm glad to hear that. It always is disappointing that we don't have a lot of information to inform our care when it comes to this population.
Kind of along the same lines, Manu, I don't know if you know this, but Ken and I are both really big gender equity enthusiasts. So I have to ask, the vast majority of your patients in both groups were males. Why do you think the numbers are so skewed? And do you think something could have been done to make the study more equitable?
Yeah, so the data which comes from trauma registries and trauma data from, if you look at in most of the low and middle income countries, and or even in developing world, is that the male population is usually the most affected, or the incidences of trauma is more in male population. This data is already there. So I think we actually, this was that mirror data which we also got in our study. Now, question regarding whether we could have actually looked at, probably doing a stratified sampling would have helped us. But then, yes, obviously it would increase the sample size to actually get that number. So, this pattern of male predominance or male preponderance is there in trauma. And the reason, I think we even wrote it in the article, that, most of the probable reason would be that males are more, most of the, in lot of all the low and middle income countries, males are the ones who are breadwinners, and they move a lot, and their risk taking behaviors are higher. So probably that is the reason.
Okay, the fifth and final question is about complications. Rib fracture complications are typically more delayed, secondary to splinting from pain. Could this intervention be repeated for continued pain control to help with delayed complications and decreased length of stay? Is that a possibility?
Repeating rather than repeating. So if you look at studies done on anesthesia, where they've looked at post-operative pain, and there are a lot of studies for erector spinae block, pain block, where they looked at post thoracotomies, post abdominal surgeries, where they actually introduced these catheters, which could be placed in the plane, and then you could give aliquots in between. So a catheter placed in the erector spinae plane, and then giving intermittent dosages could be an answer to your question of having continued pain relief, probably till 24 to 48 hours or so, and that could definitely improve the decrease the length of stay, and probably decrease the complication rate.
So, is there anything else about your trial or this area of research that you wanted to comment on?
So, plain blocks as such, as part of multimodal analgesia has actually, come in lately. If you see, this article has, just compared erector spinae with the routine procedure. There have been articles on erector spinae block being compared with serratus anterior plane block. But as such, this block specifically has a very good safety profile. Has an excellent safety profile. It doesn't have much nerves in the proximity. It doesn't have any vessels in the proximity, and it's very superficial. It's very easy block to do. And in our study, actually, we looked at NRS, which is mostly subjective, and pain is always what I feel is a subjective thing. But still, we could look at further studies could look at objective assessments of whether this is getting effective, right? Like looking at spirometric values or looking at diaphragmatic expression with point of care ultrasound. These are endpoints which could be looked at apart from the length of stay and long-term complications which could be looked at. And further adding steroids with this could be another answer to actually prolonging the nerve blocks, the effect of the block. So these could be looked at and further studies could be done on these areas.
Well, thanks for answering our 5 nerdy questions. We're going to move on and comment on your conclusions, you and your author's conclusions, and ask Suchi, can you compare them to the SGEM's conclusions?
Sure, Ken. So the SGEM conclusions align closely with the author's conclusions. We would have said that the intervention had a clinically significant decrease in pain observed in the first 2 hours, but not at longer intervals.
And can you give us an SGEM bottom line?
The bottom line is that with adequate training, effective pain control can be obtained with ultrasound-guided ESPB. Ultrasound-guided ESPB can achieve lower doses of opioid analgesia requirement for up to 2 hours after intervention.
And can you resolve the case that you presented about the 52-year-old who presented with the rib fractures?
So you're in luck. It turns out that your colleague on the other team is the emergency medicine ultrasound fellowship director and has been training herself in these ultrasound-guided plane blocks. So the patient gets an ultrasound-guided ESPB and feels much better. His overall opioid requirements are essentially nil, and he can get discharged from the trauma service the very next day. His physician daughter sends you a lovely thankful note recognizing the pivotal role that you played in making all of this happen.
And what about the clinical application of this study?
We would recommend considering ultrasound-guided ESPB for pain control in your healthier, non-pregnant patients with uncomplicated rib fractures without any lacerations over the injection site or any chest emphysema. There needs to be clinical training, operational changes, collaboration from the trauma service, and institutional buy-in for this kind of procedure to be successful. There also needs to be a plan of action for pain control after those 2 first hours after the block.
And so, Suchi, what are you going to say at the patient's bedside?
I would tell my patient, would you like us to perform an ultrasound-guided ESPB on you for your rib fracture pain? Beyond that initial discomfort of the procedure, it will decrease your pain significantly for the first 2 hours and perhaps even up to 6 hours. It will also decrease your opioid pain medication requirements. There have been no significant adverse effects associated with this procedure. What do you say?
All right, that brings us to the Keener contest, and last week's winner was Madison Osentowski. She is a PA, and she knew that TNK, or tenecteplase, was approved for acute myocardial infarction by the FDA in 2000. Suchi, what's the question this week?
This week's question is, what are the 3 categories for human ribs?
And if you know those 3 large categories that are used to describe human ribs, then send an email to the SGEM at gmail.com with Keener in the subject line. The first correct answer will receive a cool skeptical prize.
Now it's your turn, SGEMers. What do you think of an ultrasound-guided ESPB? Tweet your comments using the hashtag SGEMHop. What questions do you have for Manu and his team? Ask them on the SGEM blog. The best social media feedback will be published in AEM.
Well, thank you, Suchi, for doing another SGEM Hop.
This was amazing, as always. Thank you for having me.
Oh, it's my pleasure. And you know what? Next month, we've got a big one because we are going to be at the Society of Academic Emergency Medicine's meeting in Phoenix, and we are going to record an SGEM hot off the press episode for the release of Grace 4. So that's going to be a big one.
I'll be there watching.
And now I would like to thank you, Manu, for coming on and being the first and best person we've ever had from India.
Thank you so much for SGEM team and Ken and Suchi. Actually, really enjoyed it.
Well, I've been hanging on to this dad joke for the whole episode. It was just a pleasure to talk Manu and Manu with you. Sorry, maybe that didn't go over well. Let's see if we can bring that back. Can you read the SGEM tagline for us to finish the show?
Yes, remember to be skeptical of anything you learn, even if you heard it from Skeptic Guide to Emergency Medicine.
Talk to everyone next time.